Today's guest is Dr. Julian Grove, who is the co-owner at Physician's Choice CBD. He's also a physician partner at Pain Consultants of Arizona. As well, he's the president of Arizona Pain Society, and he also is a graduate of Harvard Medical School. Dr. Grove, welcome to the show, and let's delve a little bit into your pain management background.
Sure, absolutely. So I was sort of a typical training for a pain management physician. I went to medical school after graduation from medical school. Then I went into the field of anesthesiology. That was my residency, and that was a 4-year program at Stanford. And you learn anesthetics, putting people to sleep. There's a lot of postoperative pain management. So you become quite facile with pain medications, both IV and oral, intraoperatively taking care of patients, but also pre and postoperatively as well too. I became keenly interested in one subset of anesthesiology. You could break out into a variety of different subspecialties, neuro anesthesia, OB anesthesia, critical care medicine, but pain medicine was one of the subspecialties under the American Board of Anesthesiology. And that to me was very I was just very interested in it for a couple reasons, but primarily one of the downsides to anesthesia is that there's not a lot of long-term patient contact. You take a patient through a easy or a difficult surgery, you take them to the post-op area, get their vital signs all keyed up, check out with the post-operative PACU nurse, and then it's on to the next patient. And while I loved anesthesia, it was really pharmacology and physiology in motion. What I missed was that traditional physician-patient interaction. So pain management provided me with keen knowledge that I had gained of all the pain medications, as well as a traditional physician-patient interaction. I got to see these patients improve on a daily basis or a monthly basis or a yearly basis, or I got to see them at sort of the denouement of their disease process at the worst and got to help them get better. So I like that longitudinal assessment with the patient, and pain medicine provided that for me. It was also a little bit a procedural specialty, so I got to do various procedures that we just discussed for various types of pain, as well as medical management, which I'll sort of segue to that. I finished my training after Stanford. I went to do a pain medicine fellowship at Harvard and Brigham and Women's Hospital. It was 2004, and that was the time when OxyContin was heavily in use. A lot of fentanyl patch was also heavily in use too. It was the decade of pain. We were taught to treat patients aggressively with opioids. Part of that was government driven in terms of postoperative pain scores, getting them as low as possible. But that decade really put an exclamation point on opioids, in that I think a lot of people overused opioids or used them possibly inappropriately, or leaned on opioids to a high degree. Pain is such a stepwise process sometimes for patients. You look for analgesia, but you also gauge on safety and side effects. But I think that decade, a lot of physicians or healthcare providers leaned on opioids too heavily. It became a very prominent pill, so to speak, that was prescribed. So fast forward probably 2014, 13, we're in the depths of the opioid crisis. I practice in Phoenix, Arizona, and the opioid epidemic was coming around by the governor and the Department of Health Services to mitigate a huge amount of opioid-related deaths and hospitalizations. Most of it, in general, on retrospect, was illicit fentanyl and heroin. But in a general sense, as physicians and as patients, and I had patients anecdotally start to tell me in 2014, 15, 16, how CBD was beneficial to their pain. And it blew me away. I didn't know anything about CBD. I had to really delve in. And as a natural substance, there clearly was not a lot of context and information. And as you know, there was not a lot of data, which physicians and healthcare providers really lean on for dosing and side effects. So I was intrigued that there was a medication or a treatment that was natural, that patients were telling me really had nothing to do with THC, that they were getting benefit with. Now, separately, I also had patients who were using THC. Medical marijuana passed in Arizona, and they were definitely getting benefit with that too. One of the separating factors typically for some patients is sometimes the cognitive effects of THC are affecting them. For some patients from a work perspective, they rather pursue just a CBD isolate, so to speak. But patients were using both of these medications, all cannabinoids, THC, and CBD. And I, as a physician that tries to keep my mind open and embrace new treatments and therapies, it was clear that this type of natural medication had the potential to usurp a lot of the traditional pain medications that we prescribe. I certainly can get into it later, but there's a variety, probably about 5 or 6 different types of treatments that I use for medications, and all of them have severe and significant potential side effects. So THC and its derivatives offered me potentially a natural solution for patients in an era where we were trying to minimize, reduce the opioid prescribing to only those that really needed it.
Okay. Interesting. So it sounds like as a pain management specialist, obviously you had extensive exposure and ability to work with opiates and different modalities in treating pain. And it was only after you received a lot of positive feedback from your patients that you were open to considering the cannabinoids at all.
Absolutely. I would love to say I was on the forefront of that, but no, it was truly patients that came to me anecdotally with stories that really changed my mind. And I think I'll speak to probably the national audience in terms of the healthcare providers. There are some physicians that until THC gets federally rescheduled, they won't even touch it. They won't discuss it with their patient. You may even get kicked out of a pain clinic if you discuss it or take it. So it's a real line in the sand right now. There are people that are embracing it and seeing it as a potential for another armamentarium for patients' pain. And there are pain physicians who say, listen, I have a DEA federal license, and until THC gets rescheduled, not even touching it. Don't want to see it.
It's really interesting because I actually come from the pharmaceutical background and I have extensive experience with fentanyl and a variety of opiates from a marketing and sales perspective, as well as from a health education perspective. And what's interesting is that when I was basically a provider and in the sales and marketing of a lot of these products, I obviously went to a lot of pain offices. And I remember I had very little empathy with the patients. And I really feel a lot of times that people that are in the maybe cannabis field or people that are actually in the general public, unless they are encountered with someone that really suffers from chronic pain, they don't understand how devastating it is. For me, even though I'm a trained epidemiologist, as I mentioned, I was in the pain market for about 15 years. And until I personally was straddled with hemiplegic migraines and trigeminal neuralgia, where I was completely disabled, I really didn't understand that people can suffer that type of pain and that type of pain can truly disrupt and destroy someone's life. So, I think that's really interesting. And, I'm talking about someone that was educated and I still had very little understanding of the patient experience.
And you've hit on that point where you can't see pain. So, if you are going to the, pharmacy and you are trying to get some Percocet from your headache, that's the only thing that's helped. It's certainly atypical, but maybe that's what has helped. You're going to get the eye potentially from the pharmacist, or you're going to get judged by your friends. So, the nature that you can't see how debilitating pain is because it's such a subjective science, so to speak, really marginalizes pain patients. And I think that's why a lot of pain patients feel that their voices just haven't been heard.
Yeah. So it's kind of interesting that you mentioned that. When I actually fell sick and I was really battling kind of with my chronic illness, I lost 15 pounds and I live in LA. And of course, skinnier is better in LA. So while I was suffering on the inside, my friends actually thought I looked better. And I just remembered one of the most hurtful things from me was that lack of empathy I felt. from,
Yes.
a lot of people that are around me. So I am really grateful that you are out there educating and talking about these issues with the general public, because I think either a patient is suffering from pain and is really relieved by getting this information and knowing that there's other modalities available, or if they have a loved one or a friend that is suffering. So I want to say thank you greatly for providing a lot of education and bringing a lot of your experience into the field and talking to the general public. I think that's really commendable.
I appreciate that. I am, you've known me from a while now, and I'm a private practice physician, certainly published, but I'm not your big time academic researcher by any means. And I was shocked that when I started delving into the research study that we did, that it really hadn't been taken on by large academic centers where they have big anesthesia programs, big pain departments. And I still think, to your point, whether it's federal funding, that there is some fear about speaking out about how this is a very good medicine. Obviously, there is now a few medicines that have been FDA approved for some esoteric and small conditions, but it really boggles my mind that the pace is so glacial.
You just touched upon doing this study. Can you actually talk about the study that you did?
Sure. So when we figured that, listen, this we were getting quite a few patients who were either asking about CBD or telling us this is how they use it, and I was educating myself on dosing and tinctures and salves and creams, that we thought that it would be best to delve into this with 2 feet, meaning we want to get involved in the development, the manufacturing, the extraction process, and know everything that's going to go into a pill that I'm going to recommend for my patient, or a capsule or a cream. So, and it was about that time too, I think it was the end of 2017, that JAMA had come out with the article where they looked at a variety of different CBD companies, and the labeling was inaccurate on many, let's just say. So we decided to create a CBD and sort of nutraceutically add various substances for specific pain, meaning you well know that trigeminal neuralgia is a lancinating, severe pain, nerve pain issue, whereas osteoarthritis or sacroiliitis or joint pain is a terrible inflammatory condition. So there are many different types of pain, and you could have a tumor in your belly that's causing distension and pain, and that's visceral pain. So there are a variety of different pains. So we thought that we could identify some of the largest levels of pain, and it generally came down to inflammatory osteoarthritic pain, nerve pain, headache, and we added just a pure CBD for wellness, just without any supplementation. But we generally added turmeric, piperine, and ginger for our inflammatory brand, and alpha lipoic acid, which we had a long history of recommending for patients as a nutraceutical supplementation for nerve health and nerve regeneration, coenzyme Q10 and riboflavin for headache management as well too. So we knew that the advantage that we have was sort of an easy laboratory, if you will, of about 40,000 patients here in Phoenix and Chandler and Scottsdale.
40,000.
So we have 40,000 encounters per year. Sorry,
that's amazing.
40,000 encounters per year. We have 8 providers, and they see probably 30 to 40 patients a day. So we figured that there was ample resources and opportunity to create some data, because we really found none. I actually found an old CBD and anxiety study that was written in one of the Kaiser journals in 2000, I think it was 17 or 18. And that's really all from a post preclinical and a post in vitro studies where there was definitely CBD data, but really where the rubber hits the road in a clinical study. So we did a prospective study of looking at patients who were on, it's just 3 studies that we undertook. One was patients who were on opioids who wanted to reduce or had difficulty reducing previously on their current opioid dosage. Clearly, there was a narrative in the government and the media pushing them to do that, but they were having difficulty coming down. So we thought CBD was a great alternative for these patients that would give them some pain relief, some anti-inflammatory effect. We think that it takes advantage of some anxiety that's inherent with withdrawal symptoms as well too. But those were our first subject, is taking 233 patients, I think our N was on our 12-month study, and seeing if patients could use CBD appropriately from a dosage of 12.5 milligrams to 100 milligrams, and see if that could help them reduce their opioids. The second study was just a polypharmacy study. So we have a lot of patients who they may have a osteoarthritic and a nerve pain problem, and they are on many different medications, maybe 3 medications for nerve pain: amitriptyline, gabapentin, and Cymbalta. They may be on an anti-inflammatory medication and an opioid. So all of these medicines, with the exception of anti-inflammatories, can cause cognitive effects. So you oftentimes, with multiple medications, get drug-drug interactions. The patient gets drowsy, sedated, and you're not doing the patient any benefit at all. If they're working, clearly you're causing some problems. But even if you're not being able to interact with your spouse, your kids, getting to take that vacation, so to speak. So it was a polypharmacy reduction where we showed reduction in terms of nerve pain medicines, anti-inflammatories, which was really the key for us. We knew a lot of patients who had some stomach issues, some gastritis, or some burgeoning kidney issues that really wanted to come off an anti-inflammatory, traditional anti-inflammatory, and then skeletal muscle relaxers. And then the last study was just to look at the side effect profile. We, if I'm going to recommend this to my physician partner or my primary care friend, the first 2 questions he's going to ask are, how do you dose it, and what are the side effects that I need to worry about for our patient? So we wanted to do sort of a general side effect profile for these patients as well too. So those are the 3 studies that we took and presented all 3 at Pain Week about a month ago, and then the opioid study, the initial 10-month data, was presented at the American Society for Interventional Pain Physicians in Ohio. We have 2 other conferences, the Mayo Clinic Opioid Conference and the American Society for Regional Anesthesia and Pain in October and November, that have been accepted presentations and are going to be presenting.
So, so that the audience understands, what were some of the conclusions that, or some of the results that you saw in your patients having conducted these studies?
Yeah, absolutely. So the opioid study, I'll start with that. I think that's the one that's getting a lot of looks currently. Right now, we have a 12-month data set where we follow these patients. Again, these patients just used the CBD capsules, and it was a variety of either inflammatory or nerve. There were a few migraine as well too, and then our just wellness CBD, which is just pure CBD, full spectrum CBD. And we had those patients reduce their opioids over a 12-month period of time. Some were quick. Were able to reduce 100% of their opioids in 3 months, and some were on orbital opioid doses. They'd come from another clinic and they were on tremendous opioids, and we were able to reduce 30%, which was very palpable to them. But generally speaking, greater than 56% of the patients had greater than 50% reduction in their opioids. We often use 33% reduction in pharmaceutical studies and VAS scores as a palpable pain difference, and we had 75% of patients achieve greater than 33% opioid reduction. And then we had 20% entirely reduce their opioid burden. And that included some on low levels, but also on high levels of opioids as well, too. Let me get into the polypharmacy data here.
Just to maybe summarize this and maybe also see if there's any benefit to anyone that might be listening. So essentially, you were able to see significant opioid reduction on patients that were taking opiates but did not stop completely, correct?
Correct. Most of them did not stop completely. And I think this sort of heightens the point that CBD and CBD itself, full spectrum CBD, I think that it is a very good medicine. I think there is a lot of niches that it can be used, but is it as potent as an opioid? I would be a liar as a pain physician to say I think it's in the same ballpark. But I think for some patients who mentally can really reduce their opioids and use the benefit of the pain benefit of CBD to come down, that was there. And the 56% greater than 50% reduction, some of these patients were, third or fourth time trying to change to a different opioid to help reduce. So it's been a long haul. So those were very big wins. But to your point, Yeah, it wasn't jaw dropping in the sense that we had 80% of our patients come off opioids. Just, I don't think CBD has that potency. And I think that that's sort of therein lies, the niche that CBD may be looking at as either a primary medicine for mild or mild to moderate or moderate pain, and or an adjuvant medicine for patients who have moderate to severe pain. That's my best takeaway from the data, because as you know, there are some people who have chronic pain, but it's annoying, or acute pain off and on, maybe some arthritis in the back. But then there are some people that have, 5, 6 lumbar surgeries, 5 levels of hardware for scoliosis, and they deal with debilitating refractory pain all day long. I think CBD can help those patients, but by no means, I don't think it is prominent in terms of reducing all of their opioids. Now, the point, the narrative currently, and I don't have data on this, but I think that there's a lot of researchers who feel that THC adds a higher level of a spark, so to speak, to get a little bit better analgesic benefit. And, the capsules that we use are, 0.3%, less than 0.3% THC, a very small amount. But one of the questions we had is, are there CBD or other cannabinoid levels that can be paired with THC that we can get better analgesia? And that's just what we don't have information on right now, but is certainly those studies are certainly being looked at in terms of how we best look at that.
Right. So let's say I am a chronic pain patient and I am essentially, for a lifestyle perspective, dependent on opiates. Would your recommendation be to add a CBD or CBD tincture in addition to my existing opiates, or do you recommend the patient taper off first? What would be the ideal scenario?
Correct. I would pursue the former rather than the latter, meaning that I think, just as you said, there are a lot of patients who the opioids help. And at some point in time, they decide to say, I want to see if I can come off of the opioids. And some of the other adjuvant pharmaceutical medications that we have, have some other inherent problems that we've seen. But in terms of CBD, I think it's a reasonable point or stance to take that I'm going to add CBD judiciously and safely. And obviously with CBD, it's a very benign medication. But I'm going to add CBD and see if I can slowly start chipping away on the opioids every 2 weeks, every month, by virtue of the anti-inflammatory, the other nociceptive benefit that we haven't quite teased out potentially, and generally it's pain relief. So I would sort of choose that route, or I've seen success in that route as well. Because as you know, starkly reducing the opioids, whether it's some of the new pharmaceutical medicines or one of the new that's out there off-label, we use clonidine and, a variety of other medications, it's fraught with a lot of difficulty and a lot of other side effects.
So I guess that actually really kind of hits on the next steps that we want to talk about. There, obviously, we'll get into some of the side effects of some of these pharmaceutical medications in conjunction with the cannabinoids. But there's a lot of conversation about THCA and CBG and those types of cannabinoids. Can you talk a little bit about really the variety of cannabinoids that may be useful in pain management and what your anecdotal experience has been with patients?
Sure, absolutely. I can speak to the cannabinoids primarily. That's just been the focus of my last year. I'll certainly say that CBD THC combinations and our patients that are using THC specifically have had very good benefit, but I just don't have data to speak to on that. To your point, I'm sort of delving into some of the CBD isolates, or the cannabidiol isolates, cannabinoid isolates, that are out there. Pardon me. CBG, CBC, THCV, CBN are sort of some of the things that pop up in terms of some good data that's out there. CBN specifically had a conference about a month ago on this. Is formed with THC that's exposed to heat and oxygen generally, but CBN has had some very robust studies with bone regeneration. And you'll see a common theme in a lot of these CB cannabinoid isolates is that THC and cannabinoids, they affect the endocannabinoid system, and we'll, I'm sure chat about that, but it generally, it comes down to your body's homeostasis. You have an inherent endocannabinoid system that until recently was really not used in a medical manner. So we're excited about this aspect. So CBN, we've had some very good data on bone regeneration and its anti-inflammatory and pain aspects there as well too. CBG or cannabidiol acid eventually splits into THC and CBD, but it's sort of jewel, if you will, is some antimicrobial or antifungal data that is being looked at more and more. CBC also comes from the CBGA acid, THC, CBD, and CBCA, and that CBC has activates a lot of the general receptors that we see with endocannabinoids, the TRPV1, the TRPA1, the CB1 and CB2 receptor. But that one specifically I'll highlight just because it seems to have some preclinical in vitro studies, some robust cancer-fighting properties. Pain perception with the vanillinoid, the TRPV1 receptor, the anchorin, the TRPA1 receptor, not to get too technical, but those are common receptors that these medicines activate, and it is involved in pain perception among a number of things. But specifically with CBC, we were sort of eyebrow raising to see it was a preclinical and a rat study that was done, but decreased inflammation and decreased tumor growth too. So those are kind of the few of the cannabinoids that I've been sort of delving into specifically in terms of seeing if we can pursue those isolates, which are not as profound and not as much in numbers as CBD. That's why they're sort of secondary to this huge first wave of CBD. But to your point and to a general point, there's going to be THC as well as CBD analogs that I guarantee you will have a tremendous amount of medicinal properties that we're going to unearth.
So to extract the eagle's eye perspective, our bodies have an endocannabinoid system that needs to be in homeostasis for us to function well. Was that pretty accurate understanding of
absolutely
how it functions?
So absolutely. So not to be full of hyperbole, but the endocannabinoid system affects so many different things. And it's embarrassing that I went to medical school and had not one lecture or learned anything about it. And I can say probably 99% of other doctors are in the same boat. We have to educate ourselves. But this was, discovered in the late 80s. So medicine and research, unfortunately, moved very slowly. But the endocannabinoid system has shown absolute benefit with anti-inflammatory issues, hemostasis and autoimmune issues, anti-nociceptive benefit, which is outside of inflammatory, but pain relief in other types of factors, sleep, anxiety, appetite, memory, neurodegenerative. The issues in addition to epilepsy are being looked at, cardiovascular health, diabetes, blood glucose regulation. So there is a lot of subspecialties in medicine that are starting to dip their toes into some more than preclinical human studies to see if these CBD isolates and or THC isolates are beneficial. And looking at the preclinical studies, it looks extremely promising.
So would it be a natural conclusion to say that some people that may be suffering from some of these conditions may have a deficient endocannabinoid system where supplementation actually enhances their normal bodily function? Is that an understandable or accurate statement?
You're exactly right. So our bodies work on a spectrum, and whether it's our individual response to pharmaceutical medications, whether it's our individual glomerular filtration rate in our kidneys or our liver metabolic system, we all are on a spectrum. And from a genetic perspective, that there is a portion of patients that are likely born with a deficient endocannabinoid system and or a medical disease process has affected the endocannabinoid system, just like a medical disease process can affect your immune system and cause an autoimmune issue. So you're exactly right that there is likely a portion of patients that really truly do have a deficient endocannabinoid system, and this is a a excellent way to advance that and to test through either THC or CBD forms, getting better in many ways, shapes, or forms. Again, memory, pain, inflammation, wellness, sleep, appetite, a variety of different things.
Now, I know with our body's opiate system, as you increase your intake of external opiates, you actually might decrease the ability of the body to increase its production of endogenous opiates. Does a similar loop exist with the endocannabinoid system? And if you take an outside cannabinoid, that you may actually depress your system from producing its own?
It's a great question. I have not seen, I can't say I've seen any data on that. It may be long-term data, or it may be data that I don't know of, but I've not seen data. It's an interesting question on the chronic use of cannabinoids and if it does depress the ECS system. I think one of the aspects is that I think our level of looking at opioid receptors in the body is excellent, whereas our survey of evaluation of endocannabidiol system is not great right now. So tough question, and unclear.
We're learning more. Now, how about, obviously opiates can lead to respiratory depression. That's why we have around 60,000 deaths in the United States from overdoses. Are you seeing a similar ceiling effect or overdose with cannabinoids?
No, I have not seen one. And that is a key point in the sense that there is a argument from some people that you are, changing one medicine with a high level of dependency and addiction to another. And that's a false narrative in the sense that THC and or CBD as a natural medicine that interacts with our natural endocannabidiol system, we've not had any cases of overdose as it links to medicinal and or recreational, from what I'm aware of, THC or CBD. We were pleased in our study. We had an extremely low side effect profile that was somewhat expected with CBD, but I can say with THC too, in terms of particularly how my patients take it medicinally, I've never seen one issue of respiratory depression.
Are there other potential toxicity levels with any of the endocannabinoids, or any of the cannabinoids that you might take externally?
Yeah, so, there was, currently the data is murky. Generally, both THC and CBD are looked at relatively benign in terms of its metabolic breakdown by the liver and its excretion by the kidney. But there was a paper that came out about elevated liver enzymes about a year ago. That paper has been recently looked at, and there's been some alternative findings where it did not affect CBD and THC did not affect elevated liver enzymes. So we haven't really honed in on something that is of a primary concern with chronic THC and CBD use. There's some reports about cyclic vomiting syndrome with high levels of THC, but I don't know any case of a fatality, and I think that is an exceedingly uncommon response to THC.
Now, what about the surge of current vape deaths that have been all over media?
I'm sorry, say that again.
The vaporizer deaths that have been reported in the media, and there's been maybe at this point about 7 deaths have been reported as a result of using, it seems like, black market vape cartridges.
Yes, absolutely. There seems to be. So you're exactly right. We've had some deaths, unfortunately, with vaping. And it was unclear initially if that was the heated oil that was causing issues, the added extract for the flavor, and or the CBD or THC or nicotine specifically, and or just a heat-related temperature phenomena. Looking at the initial data, it looks to be a supply chain issue where untoward and sort of not regulated vape cartridges were introduced, which have a biochemical process that can occur that's affecting some active inflammation and swelling in the lungs, and basically your lungs fill up with fluid. So, I think that there has been some pause in the community that uses the vaping technology for these medications. The numbers, while they're unfortunate, absolutely appear to look at unfortunately, a supply chain issue where they're not sort of the regulated medications that are the medications that we're seeing in the normal consumer outlets.
So it sounds like there's some kind of an impurity that may be causing these dire side effects. Is that accurate?
Agree. Now, with that being said, I think that there needs to be caution. Anytime you expose your internal lung tissue to high levels of a temperature, there are some issues as your cilia and your very, very fragile mucosal lining in your alveoli in your lungs get exposed to this. So I do think there generally needs to be pause. I would tell my patients there may be safer ways to address these medications, certainly until we figure out the exact process of what's going on.
So what is your recommendation for your patients in terms of delivering cannabinoids into their system?
Sure. Yeah. I mean, I think currently we're dealing with oral. Obviously, we're dealing with cream and topical, where the endocannabidiol system certainly can be accessed. And then we're dealing with either the buccal or sublingual mucosa. The buccal or sublingual mucosa is sort of the side of the cheek and or the tongue, under the tongue. We take advantage of this specifically because there is first pass metabolism, meaning if you get a medicine that's absorbed in the sublingual mucosa, it avoids that first pass of metabolism by the liver. So you essentially get everything that passes through that sublingual mucosa. So it's very advantageous. You potentially may get away with lower doses and higher serum levels. And that's the bioavailability, meaning if you take 10 milligrams and 3 milligrams gets absorbed, then that's 30% bioavailability. There is, from terms of sublingual mucosa, you have a couple options. You have oil-based tinctures that became popular initially, and that can be just put into sublingual mucosa, absorbed after 10 or 20 seconds or so. There are some issues with it being swallowed, and generally, I think the sort of next generation sublingual is the sprays that are coming out, the water-based spray, where there doesn't seem to be as much swallowing of the medication. It doesn't taste typically as bad, and you don't swallow as much, and your bioavailability obviously goes up too. So I think the quickest way generally, rather than vaping, that we have is from a sublingual spray technology.
And it seems like water-based is preferred over oil-based, or what are your thoughts on that?
Yeah, correct. So water-based, you're going to have immediate absorption. So oil-based and fatty tissue can cross barriers relatively quickly, but to get the medicine out of the oil, you have to have that sit in that area generally for a little bit of time. So while oil-based has some advantages, practically speaking, we don't see that as great in terms of the best type of absorption. And there's some data that I've leaned on showing a water-based spray as about 2 times as bioavailable as the oil-based tincture.
Interesting. Now, do you recommend your patients to take a distillate and a pure CBD or THC product, or do you believe in a whole spectrum, broad spectrum product?
Sure. No, it's a great question. It breaks down to my patient population, meaning if I want someone, let's say a 75-year-old gentleman with osteoarthritis of the knee, he's got bound up with constipation with an opioid like Percocet. He had GI issues or a bleeding ulcer in his history, so anti-inflammatories are out. This is a great candidate for CBD. For someone like that, I would like to take advantage of the full spectrum CBD, get some of that full spectrum effect in play. That we don't know the data, but we know that it likely is going to be beneficial to him. So I think that would be a great option for him. That would be sort of capsules on a regular twice daily effect. And I typically tell patients to expect a bimodal effect, meaning sometimes the anti-inflammatory effect can be pretty quick. Truly, the effect on the endocannabinoid cannabinoid receptor, CB1, CB2, that receptor change sometimes takes 3 to 6 weeks. So I tell patients there can be an immediate effect and there can be a long-term effect. So to have some patience. If I have a pilot or a city of Phoenix or state of Arizona worker or someone, let's say in the military, where even low levels of CBD, the patient does not even want to go there just by fear, even with less than 0.3% in the 233 patients we studied with our opiates. We actually did urinalysis, liquid chromatography and GRAS chromatography urinalysis testing for those patients. None of them came up positive for THC. But just to be clear, if you want someone who doesn't even want to think about the THC, wants a CBD isolate, likely because of their work or they just really are just important that cognition is absolutely nothing to them, then I think a CBD isolate is preferred.
Now, there's been some isolated reports of patients, employees, or even children being tested positive for THC when all they're taking is a CBD product. Have you come across that, and what are your thoughts on it?
Sure. Yeah, no, I haven't come across that personally. I've definitely seen it in the literature. One of two thoughts comes to mind, and I generally think it's one. The one that I don't think it is, there was some recent data that came out that CBD in the stomach, part of it can be retransferred or sort of changed into THC. That data is very unclear at this time. So, and I don't think most people think that it does to an appreciable extent at all. More common than not, harken back to the 2017 JAMA study, where we're in this great time where CBD is available in so many different places that we can take advantage of this. But unfortunately, it's unregulated. So you can slap a 25 milligram capsule on a bottle, and there's really no regulation to say that that's what the THC is. And whether it's a fault of the manufacturer, whether it's a fault of the extraction process, or whether it's laziness on the company, there is nothing to say that your CBD may have higher than 0.3%, which is sort of the federal standard of THC. So I have seen these reports. My vast intuition is that the company, unfortunately, that they were using likely had higher levels of THC in that particular batch.
Interesting. So let's say you're a parent. Would you recommend supplementing your child that may be suffering from ADD or epilepsy to supplement with CBD?
So I think I absolutely think it's a reasonable option. Obviously, for epilepsy, that is a conversation with a neurologist, but to certainly bring that up, I think is important. Understanding that some neurologists may think of this or not be aware of the data and relatively defensive, but I absolutely think that from a pediatric neurodegenerative issue and or epilepsy specifically, which has been FDA reviewed, that CBD and THC blends for other very severe symptoms like MS-related neuropathy or post-chemotherapy-related neuropathy, that CBD and THC offer excellent benefits with low to no side effect profile, meaning so many of the medicines that I prescribe, there's a litany of side effects, some extremely uncommon, but many are unfortunately common. So given that, and given obviously the fragile nature of your child, for instance, I absolutely would pursue a natural, safe route, possibly in addition to a vetted out, known FDA approved route.
So many adults are using CBD as a wellness supplement. What are your thoughts on that?
So what's the last part of after the supplements? Or the wellness?
They're using it for wellness or even for mind expansion or optimization. So they're taking it, they're not ill, they're not in pain, but they feel that it benefits them from a wellness perspective.
Yeah, no, it's a great point. I think a large portion of, I'm just going to generally say the younger age group, are taking CBD for wellness. They are in tune. They understand the endocannabinoid endocannabinoid system to an extent that it is beneficial to your body. It is homeostatically acceptable, and there is definitely some secondary aspects, mind extension. You hear some stuff about that. I can't speak to that specifically, but it does look to be a relatively benign way. I don't see, and maybe the future will tell me wrong, but I don't see long-term use of CBD or high levels of CBD appreciably causing irreversible conditions that, again, many of the prescription medications that I do have the potential for.
The next question has to do with essentially pregnant women and breastfeeding women. First with CBD and then secondarily with THC. What are your thoughts and what does the science suggest?
I'm sorry, say that question again. I apologize.
So pregnant women and breastfeeding women. So what are your thoughts, A, on CBD and secondarily on THC?
Correct. So I generally, I think it's twofold, my answer. Number one is what I feel. And what I feel is that moderation is fine. Meaning low levels of, a glass of wine is absolutely fine. I deal with severe complex pain in the pregnant population, and that's a very, very difficult dilemma that requires a few different physicians to get together to see what's best for the patient. But I generally think in moderation, it is fine. Now, with that being said, I would absolutely maximize, certainly for a pregnant woman and a fetus that has no say, to start and try and maximize the only medication that we have a pregnancy class that's acceptable, which unfortunately is acetaminophen or Tylenol. But as a secondary aspect above and beyond, if that fails, I think in moderation, I think it's a reasonable issue. You tend to see some issues where the patient seemingly went to excess on that. And I think that that's where some of the problems exist.
So does CBD or THC, are they small enough molecules that they can pass the placental barrier?
I believe so. I mean, they are, I'd say, moderate sized molecules, but I believe that CBD, and I have to lean on some data that I'm not terribly familiar with, but I believe they do cross the blood-brain barrier to an extent.
Okay. And are they excreted in breast milk?
Tia, I'm not sure of that either. I'm not sure if they're excreted in breast milk. I apologize.
Okay. Well, it sounds like we will have a reason to talk to you again and perhaps explore
Perfect.
some of the
I will have to bone up on that. It's a very complex issue.
Yes. And it's a complex issue that, I'm sure a lot of your patients ask. I know I get asked that all the time. And I know I ask 10 physicians and 10 scientists, and they all have a different answer. So it would be nice to really have a conclusive answer. And I like to ask that on a regular basis to see if, there's any additional information that can be shared with patients. So let's say I'm a patient. I want to take CBD for the benefit of my health. What would be an appropriate dosage and really delivery method for me?
Sure. I think that for a patient, I'll start with this, which is sort of not the norm, but if it's a patient on pain medicines that they wish to reduce, we did see some, not linear, but some decent correlation between use of higher levels of CBD if they were on higher levels of opioid, meaning over 90 oral morphine equivalents. And lower uses of CBD successfully with lower oral morphine equivalents. So for that particular study, I just want to add that piece of the puzzle, that there does seem to be a dose-related relationship with needing higher levels of CBD to possibly come down on higher levels of an opioid. For your general patient that wants to take it for mild to moderate pain or just for wellness, I think there are two options. I think the sweet zone for our data was 25 milligrams twice a day. For chronic daily use, or 50 milligrams a day. I have patients on upwards of 300 milligrams, but those are the outliers. But I think 25 twice a day or 50 milligrams total daily dose is a reasonable level. The salve and the cream, I personally have seen quite a few. We have 100 and a 500 milligram cream. So I think that the salves and the creams are super safe. It's more of a financial, economical cost than anything, but you realize you don't need a lot of CBD because it works quite well transdermally. Obviously, use it on clean, dry skin to get the maximal benefit there, but it's great, I'm finding, for osteoarthritic and distal joints for rheumatoid arthritis or hand osteoarthritis. obviously focal muscle spasms in various areas as well too, either from a chronic pain patient or you played a robust game of golf or something like that. The creams are quite active, quite effective, I should say. Somewhat short acting, though, I think is the limitation there. The spray the spray and the tincture, I think, offer portability for a patient. From the tincture, that can be anywhere from 2.5 milligrams all the way to 50 milligrams of the tincture. There's some very high levels. Our spray has a 8 milligram dosing, which it's 8 sprays per day, either 2 sprays 4 times a day, 4 sprays twice a day, or you can do 8 sprays at the same time. So that, I think, is for patients who want the portability of CBD. They want a little bit more immediate effect, potentially, of the anti-inflammatory effect by taking advantage of the sublingual mucosa. But that's generally what I would say, probably that 5 to 10 to 15 milligram for a tincture or a spray based per day in dosing throughout the day, potentially, or all at once, I think is fine. The cream every 2 to 3 hours for persistent muscle pain. Most patients don't use it every 2 to 3 hours, but certainly can be. And then the capsules, I don't know data on any other capsules, but our capsules, the data, which I just have to lean on, is a BID dosing, twice a day dosing.
And you mentioned something about our spray. Can you talk about, I guess, your product line and how patients can reach out, talk to someone, or purchase the products?
Sure. We have been selling the product in our clinic. We have an online presence. It is the Physician's Choice is the company name, the Physician's Choice CBD. And the website is PC for Physician's Choice, CBD.com. So PCCBD.com. You'll see the spray, the capsules, and the cream. The spray is a very interesting aspect. I really truly think that this is sort of newer generation tincture. It's got a couple of significant advantages. CBD is a kind of a inherently unstable molecule. So for oxygen and for heat, it can degrade to a good degree. So the tinctures are all great just because they're in a dark canister, but every time you open the tincture, you are exposing that to some oxidation potentially. So the spray we like because it's a nitrogen-based canister, no oxygen in it whatsoever, and it's a canister, so no light at all too. So from a portability and longevity standpoint where the CBD doesn't get degraded, we like that aspect. The sort of a small, almost a little bit larger than a pen, holds 240 sprays. So if it's an 8 spray per day, you're using that every day. That's a month's worth of medication. When we have different sprays for pain, inflammation, CBD wellness, which is just pure CBD isolate, anxiety, energy, and sleep as well too. So we've had really some good luck with that. We think it takes advantage to a better degree based on our data. The CBD is a water-based spray. It's around 55 nanometers, so it's a very, very small, light spray that is just seriously missed. In fact, but definitely excellent penetration in terms of its bioavailability. So I think from a portability perspective, that's sort of our new product that we're very excited that can offer the patients a lot of portability and benefit in addition to our mainstay, which is our capsules for chronic pain patients and sleep and wellness and energy as well too.
So obviously not a lot of physicians are well-versed in really the variety of cannabinoids that can help the variety of conditions. Suppose I'm a patient and I need to find out more and I need to get treated. What do I do to get that correct treatment and reach out to the right person?
Yep, it's a very, very tough question. So we paired with an oncology group in the Southeast about 4 or 5 months ago, and I had a lecture to about 30 to 40 oncologists, and these are exceedingly smart guys that deal with terrible disease processes all day long. But it was eye-opening to me that their patients are asking the same thing that the patients are asking pain physicians, rheumatologists, primary care physicians. Can CBD help? My foray into many of the medical conferences this year has been that there it is slowly growing. But to your point, exactly right. There are a lot of physicians who still don't know how to separate CBD and are unfamiliar or unclear about CBD and THC and the possible, which is again false narrative, but the federal regulation regarding CBD. So yeah, we find pockets like in Oklahoma, CBD seems to be extremely well accepted. California, not in the medical side as of yet, but certainly on the recreational side. Arizona, it's a little bit of both. I think we've had some wins. There are a couple pain groups in the Kentucky and Ohio area that are using our product because that has been the Midwest has been devastated by opioid related issues. So I think doctors there are actively looking for natural alternative remedies. So we're finding it pretty patchy right now. So long-winded way of saying to your story, to your question, excuse me, that it can be a difficult process. I have written personally a lot of the medical science review literature on the website at pccbd.com, and I've included some blogs about how CBD can help and how CBD uses in the medical field. So I'm trying to at least have some place for physicians or patients can jump to and arm themselves with data for a talk with their physicians. But certainly any patient that has issues or would like to discuss it further, I can be reached through the PCCBD website to answer any questions. It's not uncommon. I talk with physicians across the nation about a variety of different things. Can I use this in my clinic regulatory perspective wise? What is the dosing that you use? So it's become a larger part of my day answering some questions about its medical use.
Amazing. And thank you for being available, because I think at this point, education is such a big part of really overcoming. In my perspective, it's a pain epidemic. There's a lot of people that are in pain.
Yeah, it is. And it's in a time frame where chronic pain patients have been just absolutely devastated and marginalized with inappropriate, involuntary reduction of opioids. They're looked at sometimes as second-class society members. They get sometimes a short shrift from the pharmacist. So it's a group of patients that obviously that is my patient population that I need to help to the best degree that I can. And I do think that this is a good conversation to have with their healthcare provider. I think as the months and months and months go by, they'll find this an easier conversation. But you have my email address. I'm available through the PCCBD website. So please, I am absolutely available.
Fantastic. Well, thank you greatly for all your insight and sharing it so freely with us. It sounds like it's a conversation that we need to continue. So I look forward to perhaps continuing some of the areas we didn't cover in the future. But again, thank you for jumping on, and we'll speak soon.
Thank you so much. I appreciate your time.
Thank you. Bye-bye.